when the same category of patients, they may present with more of the Pittanubandha Lakshanas or maybe the Vatanubandha Lakshanas. In that conditions, you will have more of crepitations, sputum would be more, and naturally the clinical symptoms will be more when the patient has the food. Consumption of food aggravates the symptoms. Or often the symptom also could be related to the posture. Very often, once the patient lies down at night, the symptom will be more. During daytime, in the erect posture, comparatively the symptoms will be lesser because you will have more of exudates, and that mottling which is increased along with a dense fibrous tissue formation. Dense fibrous tissue formation, as you see in the right lower lobe, one of the sample there. That would be a sign of the kaphaja, pittaja or vatanubandhi or pittanubandhi or vatanubandhi kasa lakshanas, which is another category of bronchitis. Now, this categorization of the bronchitis is our domain, Ayurvedic domain, which the contemporary science doesn't have that. And in that condition, the treatment would be, along with the Mrityunjaya Rasa, Makaradhwaja may be needed. I prefer, because it's always prolonged condition. Treatment would be more prolonged. Outcome would be rather slower. You may not see the recovery quite early. So you have to keep the patient prepared psychologically that you need to have a prolonged treatment. My advice is you have to take the medicine for at least 1 month. It has to be for at least 1 month, not less than 1 month. And these are the conditions where again the modern medicine often fails, and majority of the patients coming to Ayurvedic practitioner after 2 or 3 weeks of other treatment, they usually are of this category. And Makaradhwaja along with the Laghusuta Mishana is my preference, which gives better results. Of course, it's not only that Makaradhwaja LSM, Laghusuta Mishana, it could be any other drug which you prefer, but it should be having more Tikshna Guna and more Kapagna Gunas as such would be the choice of the treatment. Treatment has to be again prolonged, either 3 weeks or 1 month is the minimum duration of the treatment. Don't expect the results in early phase. That's one part. Next, now a bronchitis which becomes recurrent. Now, again, I use a certain of the words which are not technically perfect. A technically perfect word in that condition would be a chronic bronchitis. But I would not reserve that word because there is another interface which we can see in the clinical condition. Again, not mentioned in the textbooks. So I take all the liberty to go beyond the textbooks from that point of view. I use the word recurrent bronchitis. Textbooks don't mention about this word as such. It's a sort of interface between the chronic, so-called chronic bronchitis and the recurrent bronchitis. Of course, definition of chronic bronchitis is you should have a persistent symptom for 6 months. Then you make a diagnosis as chronic bronchitis. But you will have plenty of patients where they do not fit into that definition. That 6 months definition may not be there. But otherwise, they have all the symptoms of chronic bronchitis. And I use that word recurrent bronchitis for such a category of patients. So, whether it's perfect from the technical point of view, that's a debate issue, okay. But I think I take the liberty to do that. Now, in that condition, it's important is about the repeated history of cough and fever and auscultatory signs of occasionally bronchi. Occasional bronchi with the crepitations is one of the important signs. With the stethoscope only, you can make out. Development of the fibrous bands, as you see thick lines, like I see again in the right lower lobe, that would be one of the important features there. Basic management would be the same, but what I prefer is once the patient's acute symptoms are resolved, to prevent further recurrence, I prefer Kumari Asava. Kumari Asava as a treatment for the ama, that residual ama, is preferable. Kumari Asava along with the Mrityunjaya and Arogyavardhini, I may not use that Laghusuta Mishana to be continued in that, can effectively prolong that interval between the attacks, and after a prolonged duration of the treatment, the attacks can be subsided. So, but it requires prolonged treatment. Another important benefit would be patients practicing yoga at this stage, particularly pranayama, also helps significantly. Again, if you ask the question like whether pranayama is better or Kumari Asava better, I don't have a definite answer. Maybe equally better, or maybe one may be better otherwise. But I would give Kumari Asava to the patients because suggestion about yoga may not give me anything except Ganesh. But no. So, but okay, fine. But But that's another of the recommendation which can be given, and that's where you can see a significant outcome. So, yoga otherwise also gives results, not the other way. But in certain of such of these conditions, the changes can be seen in short duration and a significant result can be seen as such. That's one part. Next, as such. Now, the same condition when becomes very chronic. Now, another of the area where a good number of patients come to Ayurvedic treatment, usually where the patients would have history of symptoms for very long duration, years together, bronchiectasis, very troublesome conditions, and most of the times the contemporary science fails to have a satisfactory treatment. The ultimate treatment would be lobectomy, that involved lobe needs to be removed. Till the lobe is removed, virtually the patient would not have a complete recovery. Systemic complications of the infective pathology would be significantly seen in such patients, and again, it's one of the good, rather a big chunk of patients who at least visit to Ayurvedic doctor once. And most of the times, bronchiectasis patients would have seen many doctors already. They would have usually have a very thick file, so lots of medicines would be given, and their condition would be quite pitiable. So, such of the patients are characteristic of bronchiectasis, and interestingly, the number of such patients is increasing. Now, whether the number of patients is really increasing in the society, or whether the number of patients coming to Ayurvedic doctors is increasing, questionable. I don't have such a significant data or verifiable data, but possibly it could be like the number of patients are increasing in the society also. This is only my hypothesis. I am not sure about the data, but such patients are another of the problem. And I consider that as a kshatajakaasa. The obvious clinical signs of the just one slide. Kshatajakaasa, the typical presentation of, just previous, that pitam shavam shushkam chagratitam katidam bahu, the typical presentation of the sputum, which is purulent, pus-like, and one of the important clinical sign will be postural drainage. Like the sputum presenting in a specific position being more. Patient often say, like when I lie down on left side, it's more, or somebody patients that sputum is more on lie down on right side, or so on. So a expectoration quantity related to the position is one of the important key signs for making the diagnosis. When you take the history, if a patient says that the sputum is more at certain specific position, then definitely you have case of bronchiectasis. You don't have to go for the X-rays. Of course, X-rays, the typical beehive-like appearance of the bronchiectasis are seen, and that's the beehive-like appearance is the characteristic feature. And what Sushruta has mentioned is paravata iva kujan. The patient would have a sound which is heard like the paravata, parrots, the pigeons sounds like, and when you auscultate, that's a very typical sound, though it's often named as Ronkai. You do not have a technical term different than the Ronkai, but this is very typical. You'll have coarse crepitations with the Ronkas, and it's exactly like the pigeon's call which you hear, and that's also very characteristic as such. Next. Now, next slide. Of course, in all that patients of bronchiectasis, one of the important issue is you need to rule out some underlying pathologies, and significantly is the rheumatoid arthritis. Patients have rheumatoid arthritis, chronic rheumatoid arthritis, developing bronchiectasis is common, or many other collagen tissue disorders also could be coexisting, which makes the issue more complicated. And again, from Ayurvedic treatment point of view, the patients coming to us would be of that category, where there will be some underlying pathology that makes the treatment more complicated. Issue also becomes more difficult. And our cystic fibrosis, children, particularly children, it's the cystic fibrosis, which is another common condition. Of course, HIV also is common in bronchiectasis condition. So before we take the steps, it's important to rule out these conditions, and this can be done only by other detailed history, or wherever there is a need, it could be the investigation. So in case of bronchiectasis, you have to have a more detailed history workout. It's not simply about the cough and the respiratory symptoms. You have to take the other history of treatment taken earlier and the incidences, and these make the outcome poorer. When you have an underlying pathology, naturally the outcome would be poorer. And my treatment would be in that condition would be Mrityunjaya Rasa, Swarnamalini Vasanta with the Lagsuta Mishrana, and Swarnamalini Vasanta is given at the dose of lower dose, 1 gram per week. Again, not very costly. It can be again managed with our budgetary limitations. And the Pushkara Mulasava or Vasakasava. Pushkara Mulasava when the patient has pain as a symptom, Vasakasava when the patient has more of sputum as a symptom. So it could be choice, or at times it could be 1 week Vasakasava, 1 week Pushkara Mulasava. It could be changed based upon as the clinical conditions change, but the treatment has to be prolonged. I have patients who are being treated for 10 years and patient is satisfactory. Patient is in a satisfactory level. Virechana given when the patient is physically fit would help in significant resolution of the symptoms. I don't say bronchiectasis patient can be completely cured. A complete cure in a case of bronchiectasis might not be possible, but patient can be effectively managed and managed in more satisfactory level than any other contemporary methods of treatment. Patient can sustain with our treatment for years together, 10, 15 years or so on, having normal life. With our medicines, it's possible, but only thing is you have to identify that clearly and educate the patient about the possibilities. In bronchiectasis, another important aspect of the management would be the postural drainage, another lifestyle. Next slide. And that's either it could be the yoga bhastrika pranayama, or if the patient has a difficulty, a simple education about the technique of bringing out the sputum every morning would be another useful practice. It's not the steam inhalation. See, in case of the bronchitis, steam inhalation helps. In case of the bronchiectasis, steam inhalation doesn't help. I don't say steam inhalation harms, but steam inhalation doesn't help much. But it's a postural drainage where it's only holding the breath and then forcing the breath out. So something like the Bhastrika Pranayama, or if you do that methodical Bhastrika Pranayama also would be significantly useful. And this has more value than all the medical treatment. This postural expectoration has a more value than other medical treatment, and most of the times physicians may not have time to educate about the patient or this issue, but once you have educated the patient about this, patient can identify the advantage and then he may continue. Every day he may have to do it. Every day in the morning, immediately after getting up from the bed, do this exercise for 5 times. That would be quite significantly helpful in such conditions. Right, next. Now, another of the condition, pneumonia, where it's again an infective pathology. The only difference is, of course, we are now having that sequence of the infection traveling through the respiratory tract. This is one of the conditions where the infection has gone through the respiratory tract directly into the lungs. So, pneumonia express first. So, it goes into the lungs directly. The clinical features are where the patient would have a typical first 1 week of dry cough, and there will be tachypnea, the respiratory rate is increased, fever is more. Second week, there will be productive, the resolutory phase. So, you have typical course, and usual, the standard protocol is pneumonia is considered as a 3 weeks disease. So, at the end of 3 weeks, either the patient is resolved or the disease is resolved. So, of course, now it's not so critical. Now that fatal complications due to the pneumonia has become significantly lesser. So, it's not categorized as a fatal disease now, but a few years earlier, some 50 years earlier, pneumonia was considered as one of the fatal disease condition, and that's the issue, like if 3 weeks is the usual period considered. Now, the clinical features of the same is described in Vagbhata among a variation of the Vatajakasa. In the Vatajakasa, where there is a specific Vatalehi Vata Prakopita, persons who are consuming Vatala Aharas and the Vata Prakopa has occurred. In that condition, it's initially Mahavega Rujajvaram. There will be initially high degree of fever, but at the same time, it will be Shushka Kasa. High degree of fever and the Shushka Kasa, dry cough, is the characteristic clinical sign of pneumonia in the first week. Evolving pneumonitis, initial phase of the consultation. And that's exactly the clinical features. And again, one of the other sign is a Bhuktva Alpatam Vrajeta. After consumption of the food, the patient would have a resolution. Something as you see in tracheitis. Of course, it's not like the tracheitis. The fever and that dry cough is more. So, of course, there is a possibility of confusion with the tracheitis simply if you depend upon the clinical symptoms as such. But if you auscultate, you will be having very characteristic feature. The characteristic feature would be of having a bronchial breathing at the area, bronchial breathing at the concerned area, Because the pleura is involved, there will be always a localized pain over the chest cage. Chest cage pain also is one of the other clinical sign of the pneumonia. And in case of the pneumonia, if the criteria would be, if the patient has a severe clinical manifestation, total count is higher, if there is a underlying pathology, glycocyte count is more than 17,000, I prefer to use the antibiotics. Antibiotic treatment would be necessary. But if the patient has come in the second week, usually patients come to Ayurvedic treatment in the second week onwards. First week, because fever is higher, many of the patients would prefer the other sort of the treatment. And very interestingly, what I have observed is patients who are taking Ayurvedic medicines for all usual respiratory tract infections, they do not develop pneumonia. I have my patients, particularly pediatric patients, incidence of pneumonia is almost nil. Whereas if you see the incidence of pneumonia in the other category of people, incidence is quite higher. Now, I don't know, again, one of the area where we may have to have an objective study and then show the differences, but this difference is visible. It can be made out. And those who do not take repeated antibiotics, they may have a lesser chance of developing pneumonia, is my hypothesis. It's not proved with the objective evidence, but it's worth of trial. Now, that's one of the issues. And my treatment in that condition again would be, if the total count is less than 16,000, my management will be same Makardoja, Lagusumishana, Amrutarisa and Mrutinjarasa would be the same treatment. I don't make much of a difference because it's a Kasa variety. It's a Vataja Kasa variety. The only other issue is the duration of the treatment. But at the same time, there is one more very troublesome issue is unresolved pneumonia. Unresolved pneumonia is a problem for in the contemporary pulmonologists also. A pneumonia which fails to get resolved in 3 weeks is always something like a bomb, underlying bomb. So there is some serious pathology, and that serious pathology has to be investigated, and that investigational workout has to be detailed. You may need bronchoscopy, you may need cytology, or so on. So either if you have the provision infrastructure, go for the investigations like bronchoscopy or even cytology. Sputum cytology also may be required, or better refer the patient. A patient of pneumonia failing to get resolved in 3 weeks, it needs a thorough investigation, and there could be an underlying serious pathology. It could be either a tumor, it could be tuberculosis, or it could be some other foreign body which is aspirated and so on, which will be always troublesome. And once the identified condition is identified, tumor is identified, then of course you know the prognosis, then it's another issue. But that's one of the area where you'll have maximum difficulty in identifying. So you may need all the you may need an MRI scan, you may need a bronchoscopy or so on. So it all depends upon the infrastructure which you have, whether you can take up the investigation or you refer the patient where the investigation facility is available. So if a patient of pneumonia has not resolved in 3 weeks, I would refer the patient to a facility where you will have MRI scan facilities, bronchoscopy facilities. Then once the investigations are done and then the diagnosis is made out, the underlying pathology is made out, then the area is something different. Then whether you manage it or not is another issue, but that's one of the important issue which you have to be cautious.